So, can you just elaborate on why it is important to consider maternal health as a single continuum rather than separate issue?
Okay, thank you so much, Shuri, for that question. I feel like this is a very important question for this discussion that we're having because maternal health should definitely include an integrated real life system of care. So it's not right to view care as an isolated event, such as, let's say, prenatal care differently, antenatal care differently. Sometimes we even, because abortion is restricted in Nigeria, we then view post-abortion care as different from the real like the main access. So, but as each maternal care should be an integrated, uninterrupted system of services that needs to follow a woman and her newborn throughout pregnancy experience or childbirth or postpartum period or throughout unwanted pregnancy experience, decision, choice, until, the end of it. So when we are talking about maternal health, we often talk about it in parts, in broken pieces, antenatal care, delivery, postnatal care, but that is not how people actually experience their lives. It is not how life happens for women and communities in general. Their experiences are not separated, rather they are connected. So pregnancy does not exist in isolation. A woman's health is shaped by her economic situation. A woman's health is shaped by her safety at home. Yes, a woman's health is shaped by her access to information, her mental and emotional well-being, and the care she receives or the care that she does not receive. So you see, when we separate maternal health into categories, we miss the reality that is one continuous lived experience. Many systems still respond to maternal health in broken pieces. Each part is handled on its own. And that's where the gap of not meeting up with totality of what care means to the person receiving it lies. Most often we see maternal health is handled separately from gender-based violence. It's handled separately from mental health. It's handled separately from abortion care and economic realities. But in real life, these are deeply connected. Gender-based violence affects emotional well-being, safety, and access to care. Poverty affects whether someone can reach a facility. Stigma affects whether someone seeks help at all or suffers depression that leads to other issues. So when systems work in isolation, they fail to respond to the full reality of people's lives. So seeing maternal health as a continuum means we stop treating issues as separate and start responding to them as connected. It means recognizing that care does not start at the clinic and it does not end after delivery for people that are pregnant. So totality of care includes information and support before pregnancy, safety and dignity during pregnancy, emotional and psychosocial care, access to safe services, and continued support after birth. That's where we see people having depression after birth because it's just treated differently. This how it is because that's how it should be written, and the report must be given in that way in the hospital. So it also means recognizing the role of communities at this time because much of this care is already happening through grassroots networks, through peer support, through community-based systems. So if we only focus on services, we simply improve systems on paper. But if we address the full continuous flow of all these issues, we improve real outcomes because we are responding to root causes. We are responding to barriers. We are responding to the lived realities. So ultimately, health is not just, about services. It's about people's lives. And if we want meaningful change, we must move from disconnected responses to a connected approach that reflects how people actually live and experience their life. Okay, we must have to move from technical fixes like solutions that only focus on tools, system, medical intervention, without addressing the deeper social, cultural, and structural issues behind the problem. We shift from just services and, combine services plus systems that reflect lived experiences and experiences that is we connect these experiences and treat them as a whole. So that is the position we all should be. So let me just give an instance. Let's say a woman in labor you know, shouldn't just be another hospital case number 223 with high postpartum hemorrhage risk. Let's just take that for instance. We should also notice that this woman is scared. She's exposed. She wants to leave to see her baby without postpartum depression. Respecting that changes how you speak, how you touch, how you decide. Looking at, oh, why did she arrive late? To the hospital. No transport money. Husband said no. Last birth, she was shouted at the facility. All of these impact total survival. So we can see, survival isn't just medical, do the reports, treat her. It's medical plus social and should be attended to all together. I think I'll leave it there for now. Thank you, Sherry.
Thank you, Ijeoma. Thank you so much for that. I'm hoping that we have many midwives attending this webinar as well, and I'm sure that would resonate with them because we midwives are women's champions,